Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with John. How are you doing today?
Doing pretty well.
Awesome. It's been a hot minute since you were on the podcast last. Would you mind just doing a real quick introduction of yourself?
Sure. John Dominguez. I am the current immediate past president of SOMA. I'm the current honorary sergeant major for the Army Medical Department Regiment. And I did a 20-year career, the majority of it within the special operations community, and serving with multiple different units to include a special mission unit. And now I'm trying to help to give back to the community, medical in its entirety, to make things better for the next generation.
Awesome. Well, that's definitely a lofty goal there. But what I wanted to lean on is your experience, especially as honorary sergeant major of the Army Department Regiment, which is a mouthful, and as your at least past president of SOMA, just professionalizing the force. And the reason why I asked you specifically, we are constantly getting more and more medical skill requirements, and they kind of throw it under, well, you'll need it for LISCO, you'll need it for PFC, you'll need it, for these apocalyptic things that are going to happen. All of those things require more time, more training, more stuff, and, especially time. They never give you more of it, right? So while on the one hand, I definitely appreciate the professionalizing of things, there has to be some kind of give and take. And so I wanted to lean on, your efforts as far as professionalizing, what you think about that, and where's the perfect balance,
Yeah, that's a very deep and complex question.
I know.
The first interview was easy. You asked me very simple questions. So this is a true balance, and at every level, whether it be the general purpose force side or the soft side. When you look at the general purpose force side, and this applies a little bit to the Ranger Regiment and 160th, where you have that E4 medic, E4 and below medic that is in your formation. With soft, that E4 medic has been put through several different assessments, whether it be RASP or whether it be Green Platoon, and then they've gone through, and these are medics that have already gone through AIT. So then they're going through, the Special Operations Combat Medic course. They're going through SOAMIC. They're going through the Ranger assessment and validation for medics. So they're getting a lot more training and education within their formation versus the E4 medic that is done with AIT, goes to his unit, and then is in the motor pool, on that Monday or Tuesday or whatever designated day it is. And in the special operations community, whenever you take off to fly in the 160th, that's a real world mission. You're on your own once you are either basic mission qualified, or fully mission qualified. And so you don't have the supervision. You're expected to act alone independently. Well, we expect the same thing in the general purpose force. But where's the mentorship? And is it given at the same level and quality? I think it's a little bit slower. We have a lot more people within the general purpose force. So it's a little bit harder to be selective, and it's harder to get individualized training with some of them. But when you think about it, we are putting, on the general purpose force side, we're putting our youngest, least experienced on the front line to provide treatment to our warfighters. And in the soft community, when you leave the course, you are a paramedic. Is the paramedic the right answer and the definitive answer? No, but it is a certification that is recognized, at least in the civilian sector. Now, as we know, there are skill sets within the special operations community that far exceed that of paramedic. and actually the same goes for the general purpose force. However, it's not captured in the same way. And one of the big issues that no one really has brought up is, and this talks directly to your point about LISCO, is in our next conflict with the amount of casualties that are being predicted to be seen. And here you have an 18 or 25-year-old that is extremely young, making decisions and being faced with problems that a more seasoned, more experienced medic with years of experience would have a difficult time as they managed that many casualties and made those decisions. That being said, there's also the factor that may come up where you have people, their parents, their spouses, being upset with the numbers of casualties that we take in the next conflict of LISCO. And I kind of picture it much like we saw kind of in Vietnam, where we had a lot of people protesting, a lot of people not wanting to deal with the numbers of casualties. I can't imagine what it would have been like in World War II if we had the rapid media exposure, on like Normandy or, Omaha Beach, where we lost, thousands. I think that the tolerance for combat would have quickly deteriorated. But you'll end up having these loved ones, these parents, these spouses that will show up in the halls of Congress and to their senators and congressmen and wanting to ask the question, why is it that the last person that took care of my son or daughter before they passed had the same certification as the person driving the ambulance in the United States versus the person in the back taking care of the patient? And that's a very realistic question. So does that mean that every medic within the DoD needs to be a paramedic? No, but I think that we need to emphasize in the training that you have within that younger population that is in direct support of the warfighter. And we need to do some not only talent management, but we need to make an emphasis on training. But it all starts with the basics, and refreshing those, because when you look at prolonged field care and you have the TCCC as your basis, when you have that many casualties, no medic can carry enough in his aid bag or her aid bag to treat like one medic to a platoon. There's no way that you have enough stuff, let alone to go into PFC. So the logistical aspect is going to be very huge in the next conflict. Whether it be dead drops, whether it be pre-positioned equipment for them to go to. And it was recently said, and I forgot who said it, but there was an article that came out that basically stated that in the next conflict, the General Purpose Force is going to have a greater mission similar to that of SOF with irregular warfare. And not that they're going to do irregular warfare, they're going to be put in irregular warfare positioning where they're going to have to deal with these problems because they're going to have the denial of access and denial of area to be able to be resupplied or maybe evacuated. And one of the things I think that the general purpose population has to embrace is speed is security, not only for your force, but for your patients. So being able to move and move those patients out in unconventional means, procuring of abandoned vehicles that might be, around the area might be the solution in order to do a what we used to have is the ambulance transition points where you would meet up with two ambulances and transfer a patient. And those things aren't really taught. They're taught to you. They're taught to you in an unconventional sense when you go through different courses, in SOF, but they're not taught to you in the general purpose force because they stick with the curriculum. But when you think about it, you're taking someone directly off the street with a young mentality, different, a very large range of maturity levels and educational levels. and you're trying to get all of them to create a solid baseline. And as soon as they leave that schoolhouse, no matter if it's the Special Operations and Medical Training Center or the AIT in San Antonio, they leave there passing the qualifications to pass that course. Now, when they leave, they're actually going to start learning how to practice medicine. And the senior people are there to mentor them. And either, hopefully, they've got some senior people that are willing and have the time, and they're not overcome by other tasks like post cleanup or, whatever kind of parade or, is going on. But, and when you look at those things, you lose a lot of time in everything from changes of command to post cleanup to a detail for this or a detail for that, because there needs to be coverage. But where's the training? And, in SOF, we always train to build capacity. And we start at the team level, interchanging and exchanging classes with each other to be better. The medic gets better on the radio, gets better at, foreign weapon systems, and everybody kind of, teaches their skill set. So that way the team can operate when they are down a person or two. And in the general purpose force, because there's not a specific requirement to do that, a lot of commanders go off of their command list of what's going to get them in trouble, their readiness list. But in the readiness list, there's probably one block about TCCC, and that doesn't really tell you the quality of TCCC or the level or the tier that the whole force was trained to. And right now, we don't know how that's going to affect the next conflict, because I remember when Dr. Coatwalt did the study of preventable death on battlefield, that was done with one standard of TCCC. Now we've got several different tiers. Those haven't been tested yet in combat. And there's been several other changes that have been made to TCCC that have not been tested yet. One of the things that I've noticed, and there's always rumors back and forth about some people wanting to take out this piece of equipment or that piece of equipment from an IFAC. Well, medics are resilient, and not each individual piece of equipment is a one-trick pony. It might have multiple different uses, and it's up to the creativity of the medic and the experience of the medic as to how they use some of that. Looking at LISCO, one of the things that I think we need to look at is more education for non-medical people. And we also need to look at adding to the IFACs. And the reason being is because even if everyone carries a little bit more, you might be able to help out a little bit. But when you deal with patients in a mass cal, if everyone had an IFAC, you're probably going to run through it just the same. And where tourniquets are good, that's not the only thing that saves lives. One of the things that there's two big initiatives that are going on right now, and the first one in the general purpose force is to try to get the line medics to the paramedic level, which will be a good step forward.
Can I ask more about that? Because in SOF we've done the same thing, and you mentioned the family member asking the question of why the medic didn't have this same qualification. There's absolutely nothing wrong with paramedic education, but it's not in the same context of combat medicine or austere medicine even. You're dealing with different patients in different situations that you wouldn't necessarily have in a combat or maybe an austere situation that the military medics would have to face, right? Trauma medicine alone way more experience on the combat medicine side than versus the paramedic side. Likewise, I would not trust anybody in combat medicine, to run ACLS versus a paramedic who does this on the daily. So why, at least to me, it seems out of context, why are we trying to push that type of certification? It seems kind of like a square peg in a round hole kind of situation.
Well, there's a couple of different reasons. One of them is because, and I'm going to work backwards I'm going to work from the end of someone's career. Sure. If you have a paramedic and you maintain it, it also helps you to turn around after you get out. If you want to be an instructor to teach those younger generations, you have the qualification that allows you to do so. While you're in the service, going back to what I call the CNN effect, and this talks back to what the families and loved ones. We have done a horrible job in marketing medics. Whenever you see a lot of these books that are out there, they talk about combat operations, they talk about the gunfight and leading up to it, and then there's almost no books that are specifically written by line medics talking about what line medics do. And we've got so many different flavors. You in the Air Force, you've got your IDNTs, you've got several different types of IDCs in the Navy, and then in the Army, we've got your special operations, flight paramedics, the 160th, and then you've got your general purpose force flight paramedics, and you've got now granted over the years, those two have been coming closer and closer, although the 160th still has special equipment and other items that they are able to carry just because of the types of aircraft and people they support. But when it is a certification across the board that the U.S. population can understand. And at least that way, they know that it's the same type of U.S. standard of care that their son or daughter is getting abroad that they would get within the United States. But you're 100% correct. And I feel the same way. Military medics need to know the special populations aspect or the scene commander and setup of a specific scene. Probably not. We have a different system, and it is when you look at the scene commander aspect and you look at some of the crossover between law enforcement and EMS, you can have disasters that don't require law enforcement. And so you have a scene commander and whatnot. For the medics and corpsmen within the service, you are on a tactical mission, which falls upon the tactical commander. It doesn't matter. Medicine is not the mission. Medicine is a problem within the tactical mission that you're there for. So sometimes good tactics equals bad medicine. And those are the things that unfortunately a young medic doesn't get taught at a schoolhouse. Now in SOF, we know who's in charge. We get told, it's not your decision. You triaged appropriately. It's the decision of the tactical commander. And as they relay up where we're at in that, evolution of the mission, if we're on, if we take casualties on insertion, we have plans, right, for that. And as you go through each phase of the operation, but it's harder to train that on the general purpose force side because you might be on a convoy. And so what are your actions? And I've seen them be briefed overseas, and some of the actions are not they're not in depth in consideration of, okay, well, if we're at this point, we're going to turn around and go back. Well, trying to turn a whole convoy takes time, and that's going to spend a lot of time on an X. And if our adversaries develop tactics, very quickly, they're very adaptable. So if they see people trying to turn around, they're going to put other IEDs in the area because they're going to go for maximum effect. So as you go ahead and do this, they're going to continue to trip IEDs, or they're going to continue to put fire on that area. So you might be cut off. There's so many different scenarios that can happen, but we don't train a lot of that on the medical side. When you're flying in an aircraft, if there's an issue that you have with a patient, would you request the pilot to sit down? Could you have the pilot sit down? And looking in the future, where you've got time windows of space that could be denied, you may not have the ability to sit down somewhere in order to perform something that you need to perform that's very sensitive, and you cannot make the decision or make something or use a piece of equipment that you can't use a piece of equipment that you would if you were flying, but you need to be set down or be able to use that piece of equipment. We may not have those luxuries, but these are experience that, and should we base things off of experience alone? No, we need to base things on what the majority of the people are going to see, and then have them gain experience through things like podcasts, books that are published. And unfortunately, like I said, there's not very many books that are published about experiences that people have seen over the years. And so, and medics have a lot of those. If we do see books that are published on the medical side, we usually see them coming out of, Rule 2 publications and or 3. And when you see that, it is more medicine focused. It is more, surgical focused. But what did it take for that patient to get there? And one of the things I'm looking into right now, as I've seen several studies, and a lot of studies that have been done recently are retrospective, based on the data that we have gained from the Joint Trauma Registry. But you can look at raw numbers in there. The thing that I don't really see that is accounted for in some of the or noted as part of the variables is whether or not a medic or corpsman was a casualty within a certain incident, because that could explain why some procedures were done incorrectly, or why some procedures or like the application of a tourniquet was not completed. Someone could have started completing it. They started taking fire. They returned fire. They went ahead and advanced to go across the objective. And then when they returned, that patient has already been evacuated back, to a safer location, and the tourniquet wasn't finished. That is not a training issue. That is an issue because of the flow of the of combat. Yet, statistically, when it's looked at, it is judged in a black or white area, and we haven't really captured those things. If you look at Operation Anaconda, when it first started, we had Neil Roberts, who had fallen out of the aircraft. Then we had the first aircraft go down. Later on that night, the 160th, along with several operators, went in to go and try to rescue and reinforce. And the senior medic for the 160th, Corey Lamoureux, was on that aircraft along with Jason Cunningham, who was Air Force PJ. And they took fire as they were going into the valley. And Corey got hit below his body armor in his stomach. Jason got hit several times and passed away almost immediately. And there went 2 of your medics that were on that aircraft. The aircraft crashed, and the crew chief from the 160th was the person who was dragging casualties out of the back of the aircraft for those that were injured. Well, Corey was still awake, and he was telling the crew chief how to do medicine. And he's like, "What's the problem?" "Well, you see, if they go into my aid bag, get this." Well, it's kind of hard to direct somebody who's never been in your aid bag to find the right syringe, the right needle, the right medication. let me check the dose. Everything now takes a lot longer. Luckily, they had cover. But trying to do that and trying to teach someone medicine while you're injured is it takes a lot of patience. You're probably going to get very frustrated, not to mention you're in pain. And if you have them dose you to a therapeutic level of pain management, are you still going to be able to think clearly enough to be able to direct that type of care? And I really haven't seen anyone take those things into consideration. And I think that when we look at our numbers and we're making decisions, especially in different committees, that's an important factor, because we can get led down the wrong road if we don't consider the tactical situation. And unless you've been in that organized chaos, it's hard to describe to people, because there's the only ones that I've ever seen go very smoothly is when you just absolutely have the initiative and there isn't anything unexpected. As soon as you start having one or two things that weren't accounted for, you can adapt based on the trust and experience of your team. But there still needs to be more communication. And especially when you have an incident where you lose an aircraft, all of a sudden the chatter on several different nets starts going crazy. Everyone wants to know stuff. Everybody wants to get information in real time. And the only thing that they can really see is what's coming down from a predator. And not every unit gets their own predator. So we need to figure out how to create or block off the time and maintain all those other skills within the few years that we have these medics in the field as medics. When you look at SOF, you think about an 18 Delta finishes the course as an E6, and so now they're centrally promoted. They very, very well could become an E7 within 2 years, and then within another 2 years they could be an E8. So 4 years is really the amount of medicine you can get out of them. Yeah. SEAL community is kind of the same way. And then there's expected to be a team sergeant. Now we know that there's people that have longer times in SF as an E7 and can stay on teams longer. But when you look at the 68 whiskey community, there's some leeway. As an E5 and as an E6, you can still keep up with medicine and keep your certifications up. As an E7, you're kind of stepping a little bit further away and more into the management and leadership aspect. But on those worst days that rescues and situations have gone bad, whenever they're looking to put a rescue team together or mission, they're always looking for shooters, communication, and medics. And there's never enough medics. But because they know that you're not going to be able to take a mass amount of people out on the same the same aircraft that you insert people in. When they're litter, they take a lot more room. If they're ambulatory, yeah, you can, but you still have to be able to get to them, assess them, and then when you think about, let's just say 30 patients, how much medication do you need for a 2-hour flight to maintain, pain management? Or how many bags of IVs do you need to be able to put in an antibiotic? Or all these little pieces of information. Do we need a whole 1,000 ml bag, or can we do it with a 100 ml bag? Should we carry every bottle of antibiotic that we're going to reconstitute, should that have a 100 ml bag with it, so that way we can put it IV? What are we looking at for LISCO that we can shrink down but yet still be effective with? And I remember those days of carrying, like, for road marches, carrying 9 to 10 IV bags, because what are you really worried about? People going down due to heat or dehydration, stuff like that. especially in the summertime. If you're covering an airfield seizure, you're looking at fractures, whether they be long bone fractures or even someone snapping their neck and having a cervical spine injury. There's so many different things that, they could have a TBI, blah, blah. It just becomes a little bit wider. Do I need as many IV bags? No. But teaching people to pack for the mission they're going to go on is something that we look at, but how often is it really refreshed? And for medics, is it refreshed enough? And then for the tactical commander at the company level or the platoon leader, is it tall enough? And I'm talking about the actual, 11 series or the 18 series, 18 alphas. I can tell you from an academic point of view, you can read the regulations. The regulations need to be updated at times. And even though that we make an effort to do this, they don't always keep up with the tactics. And to your point about the skill sets, as we look forward into LISCO, there's been those talks about PAs and 18 deltas going into the abdomen to arrest bleeding. There's a reason we have surgeons, and they go to school for a long time, and there's atypical anatomy, let alone so many issues, and you're opening the patient up to infection. But what's the alternative? They're going to die. Should there be training? Well, no. I would love to be able to squeeze all the amount of training that we could into people, but they also have to be tactically confident. They also have to be, when we start listing all the competencies that they need to master the basics on when it comes to radio, satellite communication, foreign weapon familiarization, foreign tactics, spear tactics, free flow, room clearing, insertion, extraction, skill sets. Where's the time? You look at those 4 years, that we talked about earlier, and you start taking out the was it 240 days of leave that are in there, and then you start taking out holidays and blah blah. You whittle that down quite, very quickly, and
Yeah, I mean, I think it
right
comes
now,
down to somebody, an adult has to just say, what do you want? What do you want out of this guy? Do you want him to be like a tactical master and know all of the foreign weapons and know all of the demo and know all of the communications equipment and be able to adapt on the fly regardless of what the situation is? If you want that guy, you can get that guy. It's going to take time, but you can get that guy. Do you want a medic that is essentially a PA or a surgeon, but not the pay, that's for sure? And do you want that guy? Because that takes time. It turns out it takes, 8 to 10 years to get a trauma surgeon. Are you willing to have a school for that? Because we can make them. But do you actually want that guy? They don't. They want everything, and you can't have everything. So I think an adult needs to just look at, like, what is it you want? What is it you actually need? And then write the requirement for him.
Oh, yeah. That's the big thing, is write the requirement. It's funny. You know what you just made me think of when you said, and you encompassed all that? How long does it take? What are the stuff that you need? It reminded me of, at 71 years old, Billy Waugh going into Afghanistan. He had an incredible amount of skill sets that he maintained, but he was 71 years old going into Afghanistan. Since, Vietnam, it took him years to become the operator that he was. And there's people like him, and I know there's several people in the service. I know several guys that retired that have been happy staying as a medic on a team, that would have been happy going into a warrant position if there was one, to maintain and get those skill sets. And those warrants could have that mission to do everything, because we could mold that type of career field to support that special type of, or have the ability to expand into those special niches of medicine that are needed. But currently, with the way that things are with enlisted medicine, we don't have that capability. And in the Army, we're very, in my opinion, we're behind our sister services, in that we are the only service that does not award, or I shouldn't say award, but allow for medics to get a national provider identification number. And when you look at the IDMTs of the Air Force, they have them. You look at the IDCs in the Navy, they have them. And I've heard several reasons from people in the Army as to why special operations medics, as well as general purpose force medics, don't have them. And there really hasn't been a good reason. And most of their reasoning is anecdotal. They don't have any proof of anything that they are saying, except for their own experience and the culture that they were born into. This is something that's also being looked at, from the officer sergeant general level through the Sergeant Major John Dobbins and Sergeant Major Mike Remley. Will this assist in their ability to deliver sick call? Will this assist in their ability to become better medics? Right now, I think across the service, or across the services, we have great medics, the ones that are in the upper half. The reason that those people exist is because they're autodidactic learners. They have embraced lifelong learning. They enjoy medicine, and they want to be a medic. And we see those that are like, I've done everything I could as a medic. Let me go to PA school. Let me go to nursing school. Let me go to med school, which are great things professionally for them and personally for their families. Although we all know that I say they're great things, but at the same time, it takes more time away from the family for them to be able to achieve those degrees. The downside is that they are not going to come back to the line. And as I said, our biggest issue is that we are putting our youngest and least experienced into the most difficult situation. It's almost like the paradigm needs to be flipped. Unfortunately, as we get older and you start getting, more wear and tear on your body, your ability to compete or be at the same speed and level as the on the ground warfighters attrits. And jumping out of aircraft doesn't help. Long road marches doesn't help. When you do a 30-miler and you've got swollen knees and swollen feet, it's not really the best thing for your body. Do it once or twice so you can prove that you can do it. But after that, you really need to do it. You can use examples like Chris Ryan from the SAS, who during the first Gulf War, when they became compromised, he E&E'd all the way to Syria to get, to not be captured. That was one heck of a feat. And I think people have those, you've got your flight or flight mode, but there's another aspect to that, and that is determination. And if you are determined, you can push yourself beyond, what you think your body can do. And I think, for most of us, we found that out, through either one of the assessments or selections that we've been through. But your body attrits, and then this is where your mind comes into play. And this is where I think we have gotten to the point in medicine where we almost need to have a sub-mid-level provider that's going to be focused on the types of combat and combat engagements that we're going to see in the future. If you look at the way that we used to do things with the 12-man ODA. When we came up with SATCOM, as other systems have come up, you put that on the communications sergeant. When we got into drones, all of a sudden it's like, well, give it to them. It's electronic, it's electronic based. Well, hold on. How much stuff are you going to put in that individual's rucksack? We need to have a separate, almost MOS for this. We need to have a separate skill set for this. And, I don't know if there's been any talk or any consideration about looking at the 12-man ODA and expanding it to have those special skills, or if, like we've done in the past to build capacity, you bring them on like you do with PSYOP, civil affairs, counterintel, A, B, C, or D, to build up, a multifunctional team per mission, and you still keep the 12-man ODA the same. But one thing that I've experienced in the past is that when you bring on these augmented forces, if you bring on the same ones again and again, it's a tighter unit, more trust. They know how the team works. Everything is smoother. Whereas if you get different people every time, you're starting from square one again. So I think in medicine, we've gotten to that point to where we need to see how much stuff we can put in that 18 to 25-year-olds rucksack and into their brain. And then when you look at the more senior medics within SOF that are going to maintain their skill set through the rank of E8, and at E9 will make the decision whether they want to maintain those or not. How can we best utilize them? Because a lot of times it's a career killer, even for 68s or for 18s. If you stay doing medicine, it's going to be in direct conflict with the professional development model, which means it's going to be harder for you to get promoted. And for several people like myself, I was okay with that. I enjoyed studying and looking at how we could do things better in the field. There's no way that I think that we can continue to try to pour more information into the medics and have them maintain all those skill sets that are needed within, they might be asked of them during a combat situation, unless we split things up a little bit more. And so this is just for example, but for instance, on an ODA, if you had still, instead of having two 18 deltas, so you had an 18 delta and a whiskey 1. The 18 delta is more, yes, they've got the medical piece, but they're more assaulter focused. The medic is more like a direct support medic, but they're more trauma focused. So they don't have the burden of knowing all the assault stuff, whereas they are focused on a medical track that is going to support the team as a whole. So they're setting up the CCP. They're the ones doing certain things. Now, granted, that it will upset the dynamic of the split team concept and whatnot. That's why I said this is just an example. But there's no way that they're going to allow a direct support medic onto a 12-man ODA. So, you're going to have 3 medics now. There's just no way that commands are going to do that. But in that type of manner, you might be able to have someone just strictly focused on medicine, but also be able to, not master those other qualifications, but and also not hinder the team. So you've got, and then they can pack accordingly. So, hey, maybe they wouldn't need to carry a door charge in their pocket or carry extra ammo. They would be, kind of like a little bit of a mule for more medical supplies. But to your point earlier, what you were talking about with LISCO and building this, super medic type thing, in many cases, and Dr. John Holcomb wrote a paper about how we need to, what saves people in combat is getting them to surgery as quickly as possible. The downside of that in the engagements in the future is we don't have enough surgeons service-wide that can support each mission or each troops in contact. And the closer that we put them towards the X or the Y, the more danger they're in. And it takes too long, as you stated before, to make a surgeon versus a medic, and how do we assess what our when I say we, I'm talking as a service or as services, not as we met, in the medical realm. What is the tactical commander willing to risk? Because the gold standard is getting to surgery, and you'll have a best chance of maintaining that person within the force, which directly speaks to your readiness and your ability to maintain readiness after they have been and return to combat at post surgery. How is that going to be affected? Well, I think that the simple answer to your point is I think we need to invest more into the medics and and require more from the non-medical. Does this mean that I need a person who's never going to leave the jock or or do I need a pilot to know these medical skills in depth? No, but if you're going to be walking on the ground, you need to have a higher qualification of TCCC to include being able to be directed to administer medications by a medic or over a radio. And we focus so much on telemedicine for medics, just like there's been initiatives for triage and triage assistance for medics. For me, I think we should be looking at triage support and telemedicine for the non-medical person. A medic should know their job, should know their scope of practice, which, by the way, that is something else that is being worked on for the 68 whiskey, and it's been submitted. It's in the system. Let me just put it like that way. The 18 deltas do have a scope of practice, but and I've been out for 10 years, so I don't know if it's been re-looked at, if it's been expanded, or if it's even been updated at all. But we always used to look at the STP, and that was the standard of being able to state what the medics are responsible for, what they should do at each skill level. And that's not the way the civilian population works. So, and that's not the way the world, and our international partners work. So we need to define the scopes of practice. And this defining the scope of practice helps us with the integrated deterrent strategy that we have adopted back in 2017. And this will help us with our Indo-Pacific partnerships in understanding what our medics can do and what their medics can do, as well as our NATO alliance partners. There's several different things that we can learn from both our Indo-Pacific partners and our NATO alliance partners, because a lot of times in a lot of courses that we teach, they're very isolated, and the aperture is kind of narrow to that service versus looking at it intra-service, where if I ask a medical service corps officer to plan, and by the way, we have 3 Navy ships, in the water out here. Do they know what those Navy ships have as far as structure for medicine, how many surgical suites they have? And then the second piece, and most critical, is, are they staffed at full capacity for those? Because many times they'll leave port with medical staff just for normal operations, but if they get repurposed, how long does it take for them to plus up to have all those surgical suites manned? And how do you do that? Who do you request it through? Those are lessons learned through joint operations, but we really don't, in my opinion, those are lessons and things that should be not only taught, but exercised within each service. Because when the time comes, if you want, and we saw this in GWOT, sometimes you'd have a Navy person or an Air Force person sitting in a joint command, working the medical assets and placements and pieces of things in evacuation, and they're learning kind of on the fly. And most people they don't have the experience of initial entry. There's only a specific amount of people that get that, even on a global war on terror. Most of the time they fill in on the system, and the system was already laid out for them. In the future, we need to teach initial entry and resource procurement. One of the things as well is that SOF does that General Purpose Force doesn't do. General Purpose Force at that platoon level, they don't have operational funds, and they're given very strict rules. Whereas on the SOF side, I could go into a town and purchase medication to use on the host nation people, because either their corpsmen or medics didn't have that medication because they couldn't afford it, or it just was something that they were willing to accept responsibility for. And as you well know, we can't use Title 10 money that we bring in for use on host nation individuals. So we always had ways around doing this, and we could write it off as a de minimis project in order to enhance their medical capability of our force. The General Purpose Force doesn't have that yet. In the last conflict, we had them training and basically doing foreign internal defense, yet they did not have that resource. And those are those little tacit pieces of knowledge that get overlooked when someone comes in and says, "Oh, well, we're training this foreign force." Yes, but there's also these small little things that we're doing that you're not seeing as part of this training. Yes, any force can go in and train another force or have an exchange, but did you give them all the capacity that you have in order to be able to sustain this? And I see a lot of times with med caps, med rets, or these exchanges that go on in medicine where you'll have people go and teach TCCC. And one of the biggest mistakes we've seen over the years is they'll show them a tourniquet or a hemostatic gauze that this country can't afford. And we're taught in SOF to do country studies. Part of the country study is their economic, capacity, their current medical capabilities. So we don't teach them something they can't use. We go back to the sticks and rags, which they can do, or we find something that is comparable on the local economy, because we know they're not going to have access to be able to purchase, mass quantities of tourniquets or hemostatic agents or whatnot. So we have to work within that system. And in the General Purpose Force, that's not really taught the same way. Yet, as the General Purpose Force over the years, they had the civil affairs for the General Purpose Force that was active duty. They still have it, the reserve component, but that went away. And then we had the I forget what those teams were called. They're the assistance teams. Yeah, the SPABs. Mm-hmm. And so you have that, but when you look at the medics that they requested, a lot of them were at the E4 rank and E4 to E5. Well, what's the additional training that was given to them for them to understand the cultural sensitivities, looking at the economics? Here we just were talking for the last 20, 30 minutes about gaining education for medicine. Now we're going to throw another component onto this. And that is something that I don't know if they have a pipeline or if they had a...
Yeah, at least that particular force, that stopped, just money-wise, I'm sure. But what kind of bothers me is, why was it created? It wasn't created because we had a need. It was created because, somebody else is getting attention, I think. At least that's my opinion of it. Because they are essentially thrown together, given a large sum of money to buy the stuff, and didn't really bring any additional skills other than what their original MOS had. And so they weren't given all the extras that either training-wise special operations gets or through assessments, the other peoples are weeded out. They were essentially ad hoc, thrown together and given large sums of money, and you really can't buy your way to success, in my opinion.
I 100% agree. And one of the things too is as we were talking, you can give people state-of-the-art equipment, but do they know how to use it? And I think back to December 5th, 2001, where we had the JDAM dropped on ODA 574, and that came from a brand new piece of equipment being given to a Air Force JTAC, and when they needed to reset the machine, there was a training deficit, and so it's not always the best thing to give somebody a piece of equipment. It's just like taking out an unproven rifle. There's a reason that you go through the battle drills. Confirm zero. Confirm your before you get on mission, do some test fires. Make sure that you do some test burns on your fuse, A, B, C, or D. Right. You go through your pre-combat inspections. One of the things that we sometimes leave out in those pre-combat inspections, and I used to have my team, I was fortunate. I had several teams that were very open to things. And I think the reason being is because every one of us had already been in gunfights before. But we would go over how I pack my 8-bag. So that way they knew how to get into it, and basically utilize it. But we would do the same thing for other members of the teams for stuff that they would carry. And during that time, you just sit there, and when you've got a team that's together for a while, you can plan, your black and gold plans. If this happens, we're going to do this. If this happens here, and you just either create the SOP or or per mission, what you're going to do, and it's just a matter of, okay, we're going to put this block in here because we've trained it before. With the turnover that you have within general purpose forces, I don't think that you actually have the time to build those long-term muscle memory, abilities to pull that out of the shelf off your brain. And then one of the other things too that we're kind of lucky with in SOF is that there's times where we're by ourselves, and there's times where we have either a host nation partner there with us that's medically qualified in some aspect, all the way from medic to physician, or there's a for security. I remember I had the Romanian National Guard in Africa, and they had a medic that we had with us, which was awesome. And you immediately had the capability to talk to each other, run some drills, and build capacity, and build some other plans if this happened or that happened. They can assist you, or you can assist them. And the reason I say assist them is because there's been times where I've gotten in the back of a helicopter, and I've had the flight medic be like, "What do you want to do?" And I look at them, and just because I outranked them, I'm like, "This is your aircraft, your equipment. I'm here to assist you. Don't look at my rank. You have more time in this aircraft than I do. You tell me what you need and where I can help you." And they've got, you've got to respect the knowledge of the person that that's there, and be humble enough to say, "Oh, well, I know how to do this. I can do this procedure." And if you've got your stuff in your bag, and they're like, "Oh yeah, okay, that'd be helpful." But they've done those flights multiple times, and might be your first or second one on that, on that airframe, depending on what it is. Or you might have litter stanchions in the back of a Chinook, and you guys are just going back and forth, making sure everybody has got their the right pain management, and you're getting the right vital signs on those that you're checking every 5 minutes, those you're checking every 10 minutes, blah blah blah, however you're doing it. But there's so many patients that there's only two of you that you're working the problem as best you can. And those are those, like I said, those are those tacit pieces of knowledge that don't usually come in a book. When we're teaching in the schoolhouse like you guys do, you're just teaching the basics of medicine and hoping that, the ones that are getting the 85 percentile or above on the test, those are the ones that are going to pass the course. And all the great information that you're putting out is the basics. And as you go back, I remember when I went back as an instructor, I thought to myself one morning, and this was a couple of months in, I was like, man, I must have really wanted to be a special operations medic, because I don't remember some of the stuff that I'm having to teach in this course as I reread and, change the slides. Because I was there when we changed the course from the 4 classes a year to 8 classes a year. And then we were doing the conversion back to paramedic. And so there was a lot of, we had to redo all our slides and, make sure everything was CAPC approved. And so there was a lot going on. But, and of course, when you're the instructor, you should know, in depth, backwards and forwards, all of your classes. And then of course you had your primary class, and then you had the ones that you were backing up another instructor on. And then of course we lost them, but remember we used to have the instructor train-up days where we would go over the grading standards so we could take the instructor bias out and hopefully eliminate any subjective questions that may have come up. And it was a great process that we had. And I just don't see that in other, schools or training that I've been through that have that attention to detail. But at the same time, we train our guys to save lives. And in combat, your second place trophy is a folded flag to your best friend's next of kin. So you have to be 100%. At the downside, in that population that we were talking about, the general purpose force and some of the Rangers, the E4 to E6, the 18 to 25-year-old realm, and even sometimes beyond that, that is a state of maturity that is one of the most difficult to deal with if you don't save someone. Could you have done it better? Is there something that you missed? A lot of questions, but at the same time, one of the things that I think that we deal with as medics that a lot of other medical professionals don't have to deal with, at least in the amount of people, is that the majority of the people that we're working on, we know pretty well. We've been to barbecues at their families' houses, celebrated stuff with. Whereas when they get to the Role 3, most of the time, it's just another patient. And so whether it be mortal injury or survivor's remorse, those are some of the things that, as they're going through a lot of the courses in refresher, we touch on and soft, but those aren't aspects that we generally like to think about or train on. It's just like suicide awareness. A lot of us are like, I don't want to do this. This is a pain in the butt. Why do we have to do this every year? Honestly, I kind of still feel the same way about that. However, I would rather have a conversation about those moral injuries, because they don't just happen to medics. They happen to anyone in a leadership position. Could I have done this? Could I have done that? And I think that there would be probably better time spent on those aspects versus some of the other mandatory training that has come up over the years. And one of the great things that happened recently is a lot of that mandatory training was compartmentalized and removed and reassessed during the last year. So hopefully they'll take on other things.
Yeah.
But,
one hopefully quick thing. We got about maybe 15 minutes or so. We keep bringing up time, like a time initial training, time to get all those extra skills, time to build that cohesive team, to get all those extra things that makes our organizations work. right? To get all those little extra components and build that team cohesion. All of that takes time and time. What happens when crisis comes, all that time gets taken away. Look at, perfect example, I think, Ukraine. Their medic course was just as long as our course. It was months long. Now it's 5 days, 6 days, and now you're a combat medic and you're going out onto the front. So you get to, they weed out anything that isn't absolutely necessary. And I guess what my kind of a fear is that we're putting extra burdens that aren't necessarily a high priority when we should be focusing on absolutely mastering the basics so that the medic goes forward with those skills and is able to spend less time, I guess, at the unit mastering the basics, and he can focus on getting those extra tidbits as far as integrating with the team or just functioning in that unit. Does that make sense?
Absolutely.
Because when a crisis happens, it's too late. You have what you have. You're going.
So it's kind of funny. You bring that up. You mentioned something earlier, made me think of this as well. But it's basically goes back to the soft truths. Number one, humans are more important than hardware, and that is a paradigm where it seems when you're at peace, or you're in I shouldn't say peace, but when you're in a steady state like we are right now, that gets forgotten. And even that sometimes hasn't made it fully into the general purpose force for multiple different reasons. But just like, in soft, the second one's, quality is better than quantity. And when you look at the example you just gave of the Ukraine, they are rapidly producing these medics. And so they want quantity to be able to go out there and have a medic, but they're sacrificing the quality. And, the third soft truth, special operations forces cannot be mass produced. Well, that goes to any professional. If you are a professional in your field, to be a master and be really good at the basics, you're not going to produce that fast. And that's exactly what the Ukraine is doing within that 6-day window. Lately, we've been taking a lot of lessons learned from the Ukraine, and we've been taking a lot of lessons learned from things that have gone on in Israel, in Nigeria, in what's it called, Mauritania, Libya. There's a lot of things that are going on all over the world. What we really need to be careful on as a U.S. medical community, maybe even globally, is how we take the lessons that they've learned within that system and apply it to ours. Just because they had a lesson learned does not mean that it is 100% applicable and can transition into our capability and capacity. And so, with the Ukrainian situation, one of the things that I think is a solid takeaway is speed of security. And that is something that some people may say, well, the speed of evacuation, potentially. But, it's the right tool for the right job. But what we're doing is we're picking one or two things and saying that we need to do this as a result of that, that they experienced. When in reality, that's a tool that's in the toolbox. Maybe you need to have the capability to do this if needed. We need to have the capability to do this, but there's no one answer. And it goes back to what you're saying, a jack of all trades, right? And over time, you create mastery. And that's why, you have that saying, jack of all trades, master of none. Now, we need to create mastery at the basics level of communications, procurement, of assessing your environment, knowing the weather patterns, knowing it's funny, a lot of people, they get really, really wrapped around drones. And one of the things about drones is, depending on how dense a forest is, um, they can't make it through there. You try to put a drone in the Amazon, it's not going to go very far because there's not a lot of room to move. Um, if you look at uh, Kathmandu in Bangladesh, you're not going to fly a drone through the city unless you stay on the roads, because if you try to, and even then, trying to turn, because the way that they have their electrical system and hanging all those wires, it is like a spider's nest. They're going to get caught up. Um, we just don't see the environment, when we look at the environment the same way. So the environment of the Ukraine is not the environment globally. So we really have to be very astute and study the true environment in the land. And it's part of the METC process, right? What is the environment? What's the conditions that we're gonna be operating in? Because that's gonna limit some of our options of what tools we can use, and that is gonna give us some leeway with other options that we can do. But I think that we've been looking at this very myopically versus sitting back and truly experiencing and thinking through all the uh, avenues of different types of resources that we can apply, or education that we can apply to people to do this. And it's actually kind of interesting. One of the things that I think that we underutilize, or I shouldn't say we underutilize them, but I've noticed is mentors. And I know that when I was growing up in the military, I was lucky. I had a lot of great mentors, and they all pointed me in the right direction. They gave me instruction. They told me what to do, and sometimes they forced me to do things that I didn't think would benefit me, and I didn't want to do. And those were some of the most rewarding ones that I did. But mentorship is a great thing on certain aspects, and it can be detrimental in others. And what I mean by that is, I've seen in my career where you get certain people in leadership positions, and they're only in that leadership position for a finite period of time, and they've got blocks to check, and they want to leave that command with a great record, a high block, this, that, and the other, because the culture is that everyone wants to be a general. You've got to promote, you've got to do this, you've got to do that. That is in direct conflict a lot of times with taking care of your soldiers, taking care of your service members. And sometimes, certain commanders will say, well, that's the enlisted, the senior enlisted's job. And for me, it's a partnership. We both have to be focused on the same things. And when it comes to the way I view a command team, is that whoever the commander is that I supported, or was a senior advisor for, senior enlisted advisor for, we would become very tight, and it was very simple. I looked at it one way. I'm the one person that's going to advise you, other than, another senior enlisted person that doesn't want your job. They can never have your job. You're going to get certain people that are going to be on your staff. They're going to tell you what you want to hear. So that way you think you're doing it correctly and they're supporting you. But they are doing this to gain favor or to be on your good side. You're going to get others that might challenge you, or they might agree with you, but they have an agenda because that's the way they want things. And there's a program or something that they are trying to get through, or a vision that they have. And I always go back to the same thing, where it's like, if I say something, it's because of experience, or because, I don't have a bias in it. If I do have a bias in it, I'll clearly state that I've got a bias because there might be a service member that I think is savable, or A, B, C, or D. But the other thing is that when you look at it, go back to the heart of the mission. How is this going to save lives on the battlefield? Because in medicine or in any type of thing, how do I keep my readiness up? How do I keep the guys as sharp as possible? And is this going to add to or take away? And when you start having those little checklists, it really helps keep that edge sharp. And there was one other thing. Oh, I talked about history, and we really need to know the history of that we are. Sorry about that. I was getting a call, and for some reason it popped up on the computer. So one of the things is that I've kind of seen in this younger generation is they've got a short memory and they haven't gone back to learn the history. And a lot of times, why do you have this piece of equipment? Why do we have TCCC? Why do we have these ways of doing things? Because a lot of people fought for these things. And TCCC was definitely the right answer for the last conflict. And I think that was proven and shown to work with it, if applied within the methods that Dr. Coatwald's paper, outlined. However, will that same TCCC as a general be the correct answer for the next conflict? And transitioning TCCC into PFC or PCC, will there be enough Class 8? And if there's not, have we taught people how to procure Class 8 in a foreign country? Whether by battlefield recovery or if a town is evacuated, where could you go to find sterile type of bandages or medications or oxygen for that matter? And I remember in Haiti, we would go to a welding shop to get the oxygen. These are things that, like I said, in that younger generation, it's hard to teach those one-off experiences. But hopefully some way we'll be able to capture all those, because just like you, me, and a lot of people have those little one-offs, and they don't belong in a textbook, but more as more of an episodic type of thing that may not come to your mind right away. Just like I remember one time we were in Africa and we had 2 vehicles, and one of our spare tires had became inoperable, and we were getting ready to go out on a mission. And while we were looking, we're like, well, we've got 1 spare tire. The odds of us getting 2 flat tires is very rare. And so I was still loading one of the vehicles, and then one of the guys came up and said, "Hey, this tire won't work on both vehicles. This one has 6 lug nuts. The other one has 5. So really, if we go, we're saying that this vehicle is totally down." And it wasn't like we could get another tire or even that other tire fixed. It would have, the whole mission had to be scrubbed, but all because of a tire. And but that was the call that had to be made, because there was no way that we could accept that risk. So we left it up to the command. Like, do you want to accept risk on this? And they're like, absolutely not. Let's, we'll send you guys a tire. It took a week for the tire to get down to us, but we called off everything for that, and we basically stood down. But that is the type of thing where that's a commander's call, and you just give them the information, and here's a call. And the same thing in medicine. It's like, if we don't evacuate these 3 individuals, their chance of survival will be unfavorable, or unlikely. and it's up to them to make the call whether or not they're going to use the resources.
But I really appreciate you jumping on and walking through this.
Anytime. Thank you for inviting me. It's a pleasure being on here.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.